Thank you for joining us at the Nox Medical Live Symposium session, Bridging the Gaps in Sleep Medicine, Advancements in Diagnostic Technology, and AI-Driven Solutions. Insufficient sleep and untreated sleep disorders are a global epidemic. Here is a staggering statistic. Around 1 billion persons worldwide are expected to suffer from sleep apnea, and around 80% of those are undiagnosed. Individuals with chronic conditions face an escalated risk of developing additional chronic diseases due to the compounding effects of untreated sleep disorders. Cardiovascular issues, metabolic disturbances, and weakened immune responses are among the array of potential health threats that can arise from or misdiagnosed sleep conditions. Furthermore, for those entrusted with safety-sensitive responsibilities, such as transportation or critical operations, the misdiagnosis of sleep disorders could lead to compromised alertness and decision-making, elevating the risk of accidents and endangering lives. Thus, the imperative to ensure the availability and accuracy in sleep testing becomes a pivotal factor, not just in personal health, but in the broader spectrum of public safety and well-being. In the modern landscape of healthcare, the significance of accurate home testing has become increasingly undeniable. As we delve into the complexities of diagnosing and managing sleep disorders, it is clear that the home setting has emerged as a pivotal arena for sleep diagnostics. This significance becomes even more pronounced when we turn our attention to populations grappling with chronic conditions, where the reverberations of untreated sleep disorders extend far beyond sleepless nights. Furthermore, the link between undiagnosed sleep disorders and the development of chronic diseases underscores the urgency for comprehensive intervention strategies. The symposium today will focus on how home sleep apnea testing can be a vital tool in providing better access to sleep diagnostics, but at the same time, we have to be mindful in not opening up another gap in care, which could lead to or undiagnosed sleep disorders. I would like to introduce our three distinguished speakers for today's symposium. Snorri Helgason, who's the Director of Market Access at Nox Medical, and he will be doing an introduction and care gaps. Dr. Susana Sousa, who is the Head of Sleep Medicine Center in Hospital CUF Tejo, who's a pneumonologist, ESRS somnologist, and Associate Professor at Nova Medical School, will be telling us about a wake-up call, time for arousals. And then Jón Ágústsson, PhD, who's the VP of Artificial Intelligence and Data Research at Nox Medical, will be talking about Body Sleep 2.0, welcome to yet another revolution. We will have some time for a Q&A at the end of the symposium, so please feel free to submit your questions in the chat, and we will try to get to all of them at the end. Up to you, Snorri.
Yep, here you go. Thank you, Heidi. I realized I should have unmuted myself before I shared the screen, but here I am. So thank you all for joining us on this session, and I want to start by thanking the ESRS for making this possible. It's a great meeting. We are excited to be a part of it. Like I said, my name is Snorri Helgason. I'm the Director of Market Access at Nox Medical. And I really want to make use of the opportunity to introduce a concept that we've been talking about for years now, and more or less guides, our strategy as a company and how we can help solve the problem of proper sleep care management. So, just making a short time about what are care gaps. Care gaps are areas where patients are not receiving the care they need, or where patients are not effectively getting the care they need to manage a health condition. And last but not least, a care gap is also where care is not effectively delivered to prevent diseases. And I think this is definitely something that the sleep industry has been struggling with, if you will, for many years. And we tried to solve this with home sleep apnea testing, but inadvertently we opened up other care gaps along the way. And I want to talk a little bit about that. But to further explain what the care gaps are, I want to present to you a simplified picture of the care paradigm for sleep patients. Every patient needs to become aware of their conditions. They have to understand that sleep is a serious disease. They have to understand that this is a disease, and it really starts there. And this is definitely something that has been getting better throughout countries. Patients or people are prioritizing their sleep, much similar to exercise and healthy diet. They are understanding that sleep is one of the pillars for good health. But this is also important for the providers that actually see those patients. They need to become aware or better aware that sleep is a serious condition. Sleep issues are serious. Next step in the patient care pathway is that the patient will seek help. If all goes well for this particular patient that needs help for the sleep disorder, the patient gets diagnosed with a sleep disorder, or at least undergoes a diagnosis procedure. A treatment decision is being made, followed by a good diagnosis. Adoption of treatment happens after that. And if all goes well, this particular patient continues to be taken care of. This can range from, all of the sleep disorders, and this audience here today, you are the specialists here. But what I want to talk about are the gaps or the issues in this particular patient care pathway. And I want to focus specifically on the part here where it comes to diagnosis. But the first gap is really the lack of awareness. And this is huge. In most of the countries, most of the sleep industry is struggling with this. We're trying to reach our primary care physicians, the people that are not sleep experts. We're trying to understand, how do we make people aware that sleep is a serious health condition, or sleep issues are serious for your health conditions. Second gap is, okay, you're aware of that you need help, but you don't have access to sleep specialists, or you don't have access to proper sleep diagnostic studies. So this is a big gap. And I think home sleep apnea testing helped a lot with closing this gap for many patients. We increased access to sleep studies tremendously through home sleep apnea testing. But it kind of opened up another gap, which is here between diagnosis and treatment decision, that we really, in many cases, have poor home sleep apnea testing to make our treatment decision on. And this is a big gap. And I think what we want to talk about here today is how do we do a better job in elevating the quality of home sleep apnea testing that we're sending patients home with. The fourth gap is obviously you send the people. It's maybe a gap. You can look at it like this: that the patient is you have a wrong treatment decision here, and the patient either falls off completely, and you will never see them again in the care pathway, or they simply receive a wrong treatment or a wrong treatment model. So I'm not saying that we should replace everyone. Everyone goes to CPAP and we're doing something wrong. It's also for those that received CPAP, should have received CPAP, but we are not adopting the treatment correctly for those patients. And last but not least, and this is the most important part, if any part of this, gap 1 to 4 is missing, the patient will suffer from chronic diseases or chronic conditions. And we have an opportunity to basically fill those gaps to help patient populations with those chronic conditions that they suffer from because they don't have adequate sleep. We have an opportunity to improve health of populations through accurate sleep diagnostics and through value-based sleep care management. And I think this is the most important part here. And it really is connected to the lack of awareness that sleep is an important part of the individual's health. And I think this is an opportunity for the sleep industry to kind of wake up and understand that if you want to take care of the patient, and if you want to understand, how can we use sleep as an intervention strategy for chronic conditions and diseases, we need to understand how we close those gaps along the way. So I'm not going to keep my part of the introduction longer because I want to give space to the specialist. So without further ado, I'm going to stop here and stop sharing my screen. Dr. Susana Sousa, welcome.
Thank you. Good afternoon. I am very honored to be part of this symposium, and I would like to thank Nox for this opportunity. You know, sleep apnea is undertreated and undiagnosed, as we heard before, despite the development of new technologies to diagnose, new tools to understand the disease, new machine learning tools that give us many information about the disease. So this symposium is about the future, and I hope that the future is close. I have nothing to declare. This is my agenda for the next minutes. And let's think about medicine in general. When you think about a disease, we need metrics. We need a metric, and we need a system for measuring something. We need to understand what's normal and what's not normal. We need to understand what's severe or unsevere. We need to evaluate the outcomes in order to improve the care continually. Besides metrics, we need a threshold. This is the best definition I've found about the threshold. Nothing happens until the signal passes the threshold. We need the threshold, we need numbers to understand what's healthy, what's unhealthy, what's severe, what's non-severe. And talking about severity markers, we need another number. We need to know who to treat, when to treat, and who will benefit the most with the treatment that we propose. So sleep apnea has, over the years, been recognized as looking to a single number, to AHI. The apnea-hypopnea index has been the number, the magical number that defines how to diagnose, what's the severeness of the disease. But looking at this single number, it's looking to sleep apnea as a one-trait disease, just as an anatomical problem. Let's look at COPD. I'm a pneumologist, so the first example I can remember is a respiratory disease, but I'm sure there is many examples in other areas. But over the years, we looked to COPD as a functional disease, and we looked to FEV1 to establish the diagnosis, to establish the severeness of the disease, to program the treatment. But over the years, we understood that FEV1 was not enough. And today we look at COPD as this complex disease where we look to FEV1, the other parameters of obstruction, the symptoms, the exacerbations, and we can integrate all this information with comorbidities and then plan the treatment and evaluate the outcomes and look to the continuum of care. Let's get back again to sleep apnea. There is a increasing recognizing of everyone that sleep apnea, it's not one trait disease. Sleep apnea is complex, has this multifactorial nature, and over the years, many phenotyping traits were described to understand what are the mechanisms there underlying the disease, and what are the comorbidities that are linked to the prognosis and the disease. So when we look to AHI, we already know that the number of events per hour, the number of respiratory events, apnea or hypopnea, were linked to severeness and to a higher probability of mortality. But over the years, we understood that it's not the number only, but the time also matters, because the duration of events was also described as having an impact on mortality. Shorter respiratory events were linked to a higher mortality in two big cohorts. So concern has been raised that AHI fails to capture the physiological abnormalities that underlie the cognitive cardiometabolic effects of sleep apnea. So alternative metrics of sleep apnea severity have been described over the last years, and we know that hypoxia measures are related to sleepiness and to cardiometabolic effects of the sleep apnea. But beyond frequency, beyond the number of desaturations, also the depth and this area under the curve of the oxyhemoglobin curve was also described of having an impact on cardiovascular mortality. Besides, hypoxic burden, collapsibility, and loop gain were also described as an alternative metrics and being related to give us some information about the phenotyping of the patient and help clinicians to understand what's the best treatment in order to the personalized treatment that we want. So combining hypoxic burden, collapsibility, loop gain, arousals, scoring can also give us what we need to understand the qualitative phenotyping that will help us to program the future. And let's look just to arousals to have this wake up to this time for arousals. Arousal frequency has receiving attention as it has been found to be a better predictor of sympathetic activation and cardiovascular complications comparing to AHI or hypoxemic levels. So frequency is important, and we know that not all of the respiratory events finish with an arousal, but when it does, they are more profound, have a higher duration, more negative epiglottic pressure, and a higher desaturation. Besides frequency, morphology, arousals are different from patient to patient and have a different morphology over the night. And the arousal morphology can give us information about the nature of the sleep disease. The timing of arousal, it's also important. We know that most of the arousals show from 6 to 14 seconds after the respiratory event, and this can have also an impact of the knowledge of the disease. Another alternative metric, more recent, it's the sleep depth. These odds ratio products that give us a marker of sleep loss over time and has been linked to cognitive consequences, risk of car accidents, so give us more information. Arousal threshold, it's a phenotype that's one of the most important to understand what's underlying the mechanisms of sleep apnea. And arousal intensity. I'm going to give some more time to arousal intensity because we know and has been described recently that all the arousals are not equal and they can vary over time and vary along the same night. But we know that higher intensities of arousal bring us greater increases in airflow and muscle activation. And this is independent of the preceding respiratory stimulus, but is has a higher link to arousal-related tachycardia, and it's a marker of heart response rate. And maybe because of this can be this marker of autonomic activation and can be a distinct trait of the disease. And I'm talking about, as we talk about tachycardia, I'm going to talk about this subset population of patients. We know that atrial fibrillation is one of the most common arrhythmia in the world, and sleep apnea is one of the most common sleep breathing disorders. So it's quite frequent that we can find both in the same patient. But we know also that untreated, undiagnosed sleep apnea in these patients relates to a worse prognosis of atrial fibrillation, worse response to treatment even after ablation procedures. So we are just showing some results and published data about a study that we are doing with atrial fibrillation patients with the collaboration of the Nox team. And we have already 100 patients. This is our preliminary results with the first 61 patients with atrial fibrillation with or no suspicion of sleep apnea, mostly non-sleepy patients, as it's quite frequent in the atrial fibrillation patients. But all of them are have an AHI superior to 5 events per hour. And when we look to hypoxic burden or to arousal index, both have a statistically significant difference in the severe population, but we think that sleep fragmentation induced by this arousal index so elevated was going to be related to hypersomnolence, but in our patients there was no correlation between hypersomnolence measured by Epworth Sleepiness Scale and there was no correlation between the arousal index and the hypersomnolence. This is an algorithm that we made in collaboration with cardiology that was just published, because we think that every patient with atrial fibrillation has to be tested and has to be diagnosed. So the treatment of the sleep apnea has impact on the prognosis and the evolution of the atrial fibrillation itself. So we have to be sure that we can diagnose and identify this subset of patients that worries us as others. And we understand that sleep fragmentation induced by these repetitive arousals can be an important metric in this subset of patients, and combining the arousal threshold, the arousal index, the hypoxemia measures, and the respiratory events can give us the whole picture of this kind of patients. So as final remarks, we know that AHI can give us the whole picture of sleep apnea. We know that it's inadequate and insufficient to define the disease, to give us the real severity of the disease, and efforts have to be done to characterize the disease, to phenotype, and to personalize treatment as it should be. We have to make an effort to diagnose, but it's not only to diagnose, we have to classify according to severity, we have to establish the treatment and evaluate the outcomes in order to qualitative phenotype this patient. Different approaches have been done. We have to evaluate the symptom subtypes, as we know that the sleepy patients probably are the most who benefit the most with the treatment we proposed. We hope that the genetic studies that are being made can give us some answers to understand the difference that we see in every day in different patients with the same AHI. We hope that blood biomarkers can give us some issue to understand with non-polysonographic items to understand the disease. And we hope the machine learning can give us, and I hope that the next presentation will give us these answers. So in order to understand how to put all of this in our clinical practice, and the machine learning and all the personalized treatment that we want depends on all of these items to be sure, and as in other things in life, the whole is so much more than the sum of its parts, and you got to get the whole picture of our patient. Thank you.
So thank you. It was a very nice presentation, Dr. Sousa, and I really enjoy following it because I'm also talking about arousals. My name is Jón Ágústsson. I'm the VP of AI and Data Science at Nox Medical, And today I'm going to talk about an algorithm, an AI algorithm that we are researching at the moment. It's not been released in any medical device, and it's called the Nox Sleep 2. I'm just going to share with you a little bit, how we approach AI in medical devices and show you very preliminary results on what we're seeing from this algorithm. So let me start with this very nice picture. And I'm sure all of you know much more about sleep staging than I do. My background is from engineering. But the reason I bring this up and the very brief history of sleep staging is that I think it's a great example to illustrate, how AI and AI approaches, relate to what humans have been doing for a long time. So if you think about what Raksaf and Kales were doing when they were figuring out, the sleep stages and the epoch and, grouping together epochs that looked similar on the paper, they were using a method that today in machine learning we would call unsupervised learning, meaning that they were just looking at the data and finding what looked similar. And in particular, this method would be called clustering. If you think about what happened next, I'm sure that they, once they had figured out what they had, the sleep stages and everything, they probably went around teaching their colleagues how to do the same. But now they had examples. So they had examples of what does wake look like, what does REM sleep look like, what does non-REM sleep look like. And they would go probably around and show them with colleagues and see, look, this is wake, this is how it looks like. Here I have an example of this and that. And so this is what we would call today in machine learning supervised learning. So where you have the data and you have the answers and you're showing someone, how you can get from this data to the answer. What they did probably also was that they probably described to people, when you're looking at wake, these are the things you should be looking for. And this would be today called feature engineering. So when you program into the computer what things you should be looking for in the data to get to the decision. And if you imagine that they maybe had also colleagues abroad and they would train them in scoring sleep over correspondence. They might just take epochs of wake and they would write on the page wake and send it in the post. And there would be a sleep technician or a sleep scientist probably at this time and would get this. And they wouldn't get any instructions. They would just get the EEG, say this is EEG is wake, and they would have to kind of figure out their own ways of learning what is wake and what is REM sleep and non-REM sleep. And this is a little bit similar to what we do in AI today when we do deep artificial neural networks with no feature engineering, is that we just show them the model. This is the raw data. This is what it should represent. So wake, REM sleep or something like this. And it's just up to the model to learn how to determine what is wake, what is REM sleep, and what is non-REM sleep. And this is similar to the methods that we are using today in AI. Now, I've been mentioning AI and machine learning without maybe introducing what that means. And a very brief introduction to artificial intelligence or AI. I think this tweet captures it pretty well, how we use it in day-to-day language. When it's written in Python, Python is the programming language that we use when we're building these models. It's probably machine learning. If it's written in PowerPoint, it's probably AI. Meaning that people are using these terms over all kinds of different methods where you have a computer model which learns to map an input to an output. It can be complicated, deep artificial neural networks. It can also be logistical regression or even something simpler. And since, I'm showing you slides, I will talk about AI throughout. But, it could be referring to any of these things. But I think the concepts that I'll talk about, they still apply, whether you have a very complicated model or very simple model, but kind of the concepts, they still apply. I want to talk a little bit about AI-enabled medical devices. And, I think just 1 year ago, the AI was the discussion about AI was not at the same place as we have it today. Kind of when we had these generative AI models, which are generating text or images, I think a lot of people realized that the AI is here and it's very powerful and we can use it to do a lot of things. And it's a very positive thing that people are actually conscious about it and they're actively engaging in the dialogue. So the current status is that there are many different approaches to AI. I think the one that's most talked about today is generative AI. So like text generation, like ChatGPT or image generation. But we also have like AI systems that learn continuously. We have AI systems which are autonomous, so they make decisions without any involvement of humans, whereas other AI systems, they also require the input of humans. We can use it to extract new information from data that we usually measure. So for example, in the body sleep version 2 example, we're using breathing data from the respiratory bands and activity to infer wake, REM, and non-REM sleep. So that's new information from data that we're usually collecting, or automating manual work. And this would be, using AI to score sleep stages from EEGs. So what humans typically do, and just automating that. And when you think about these different kind of approaches to AI, it's very easy to imagine that these different approaches, they may raise certain risks, while other risks are maybe more related to other methods. And so thinking about AI and if you think about, what are the risks involved in AI, you can't generalize too much. You kind of have to be a little bit specific in, what is the problem that you're solving, how are you solving it, and what are the implications of your approach. And we are all learning, and I think this is also very positive at the moment, is that we see there's a lot of engagement in society to learn about AI and how to best use AI. And we see that the regulators, they are updating their requirements and changing kind of the regulatory approaches and updating it to being used with AI. I feel that the vendors are also improving. So as vendors, we are becoming more conscious about, being transparent about what we're doing, trying to validate more and kind of being more responsible in releasing AI products. The end users are also becoming more involved. And I think this is absolutely critical, because the end users, in the end, they have to be involved the whole time. And we'll talk about that maybe a little bit more. And then governments are also catching up. And there are talks about passing all kinds of AI legislations in different countries. So, I mean, we feel it in society, it's becoming more of a relevant topic. In 2 years ago or something like this, regulatory bodies in the United States, Canada, and the United Kingdom, they made this list of what they call good machine learning practices for medical device development, guiding principles. And it's a 2-page document. I just copied the bullet points from them. But I think they're very nice because they kind of capture a lot of important things to think about when developing AI-enabled medical devices. And the first point is multidisciplinary expertise is leveraged throughout the total production life cycle of the product. And I think this is very important. So when we're developing AI-enabled medical devices, it's not enough that you just have a bunch of engineers working together creating a model, but really you have to engage with, both the engineers, the clinical experts, and think about the whole ecosystem where the model will live in. Of course, you have to have good software engineering and security practices, and this is, of course, just for all medical devices. When developing the AI medical devices, thinking about the clinical study participants and the data sets are representative of the intended population that you're going to use it on. And I think this is very important. And it's one of the challenges that we face as a medical device industry is actually having access to large representative data sets. And then when we have these data sets, it's really to drill down and try to identify patient populations where our AI-enabled medical devices are likely to have lower performance or maybe not be suitable at all. So think about an example. If you have an algorithm which is scoring sleep stages from EEGs, it may not perform very well on patients suffering from narcolepsy, for example, because these are very rare patients. They might be underrepresented in the training data, and they are also patients where it's very difficult to score the sleep. So kind of drilling down into these nitty-gritty things are very important. Training data sets should be independent of test data sets. And I think like when you read it, it sounds very obvious, but this term independent can be interpreted in different ways. Of course, you don't want to use your training data as your validation data. But I also have a funny story from Nox when we were trying to be very independent and we used data from the United States to train our model and data from Europe to validate it. Then it turned out that in the United States, electricity runs at 60 hertz. In Europe, it runs at 50 hertz. And just this 50 hertz noise that was picked up in the European data totally messed with the model. So being too independent can also be a problem, but kind of determining where the line is and being able to justify how you separate your training and test data set is super important. Of course, also selecting the reference data sets that are based upon best available methods. I think that's a given. And also thinking about the model design. So it's tailored to the available data set and reflects the intended use of the device. I think it's very easy to take very simple problems and develop very complicated models to solve them. So as a hypothetical example, you could think about doing a model that's supposed to detect drops in oxygen desaturation. This is an algorithm which can be very easily written out in an explainable manner so that humans would understand what the program is doing. But you could also train a very big, deep artificial neural network that would give you output, but it's impossible to interpret what's going on or kind of understand why they're making these decisions. So going for simple models, I would always recommend this, but you kind of have to choose the correct tool for each case. Number 7, I really like, and I think it's also super important, is focusing on the performance of the human AI team. And how I interpret this is that once you deploy AI into an operation where you have humans which are working with it, you have to be thinking about how will it impact how the humans make decisions. For example, you can think about some physician that's using an AI to score sleep in adults, using an AI medical device which is intended for adults, and they get super performance and they can save a lot of time, they get better outcomes, and everything is great. And they start believing in it so much that they start to applying it to pediatrics, where it's not intended to be used. So the performance validation may not be relevant anymore. So thinking about, do the humans start to trust it too much? Do we have to educate them? How do you communicate this? And how does it fit into the ecosystem that it's being operated in? And then testing demonstrates device performance during clinically relevant conditions. And I was very nice in the sleep conference last summer. I think it was Emmanuel Mignot who said this, and I wholeheartedly agree, is that the validation of the AI-enabled medical devices only encaptures the performance in the conditions that it was validated for. So if you try to validate something that's supposed to be used in clinical practice on data that's coming from, let's say, healthy young individuals, your performance may not translate to that. And number 9 is also super important, and this is important to both those who develop the devices and also those who use it, is that the users are provided with clear, essential information. And I would like to add to that the users, they also receive it and they read it and they understand it. So the users have to be engaged in this. And then, of course, for all medical devices, you have to monitor the performance once you have deployed it into the market. And monitoring performance of AI medical devices is of course very critical, especially thinking about, if the devices that are recording the data change, how does it impact the model, or if clinical practices change. I think this is a great, if you kind of want to brush up on this, I think it's a great list to review. And also, if you want to dig a little bit deeper, there are recent guidances. So there's a guidance on how to interpret the risk management standard for medical devices, which was released this year. And also the FDA has this document, which is the Marketing Submission Recommendations for Predetermined Change Control Plan for Artificial Intelligence. It's a handful, but I would say Appendix 1 raises a lot of very good questions that is important to keep in mind when you're releasing AI medical devices and also when you're using AI medical devices, kind of empowering the user to ask these questions of the vendors. I was also Ding Su in the Gothenburg group. He also pointed me to this very nice paper that was released just last week by the ASM AI and Sleep Medicine Committee, thinking about helping clinicians to understand the current state of AI. So would recommend that as well. So Nox Body Sleep, kind of switching gears a little bit. So at Nox, we released this algorithm that we call the Nox Body Sleep a few years back. So this is available in so not in the United States, but I think in the rest of the world. Many of you may have seen it. And what it's doing is using the RIP sensors and the activity to estimate, so this data to estimate wake, REM, and non-REM periods. And the intention was, when we released this, was to get a better estimate of the AHI from a home sleep apnea test. So kind of closing this care gap that Snorri was talking about. But as Dr. Sousa also mentioned, arousals are very important. And when we released this and we started looking at the data, we realized that arousals play an important role in scoring the scoring hypopneas and to determining the correct AHI. And this is what we are doing now. We're working on this, what we call the Nox Body Sleep version 2. So it's still just under research, but the intention there is actually to be able to score arousals using the RIP and activity data to improve hypopnea scoring. So that's the intention. I'm just going to share with you, preliminary results and talk a little bit about what it's doing. So like Snorri mentioned, when we released home sleep apnea testing, there was maybe a care gap that was opened because home sleep apnea testing tends to underestimate the AHI compared to PSD. So here I'm showing you data. This is from PSD sleep studies, and we can treat the PSD sleep studies as if they were scored as PSD sleep studies with sleep stages and arousals, or as if they had been scored as HSAT studies where there were no sleep stages and no arousals. And we see overall that the points are lying below the line of unity, the green line. And the points that fall into these red zones, if you're choosing an AHI cutoff of, say, 15, these are people who would have gotten an incorrect result from their HSAT sleep study. And we see in the table there that there's about 470 people who would get the incorrect result. Majority of those are getting too low of an AHI. And the red circle points to a point where the REI from an HSAT would have been 0.8, while the AHI would have been like 22, 23, something like this. So it's a huge impact. It's not like everyone is like 20% less. There are individuals that are hugely impacted. The ASM, of course, recommends using the arousal-based scoring for hypopneas. And when we look a little bit deeper, there's literature saying that there are specific groups of patients that are more likely to have hypopneas that end in arousals. And these are typically younger people, non-obese, and women. So there are specific groups of people that are kind of underserved in the home sleep apnea test. And these are kind of the things that we want to correct with the body sleep version 2. Now I'm just going to show you a little bit of statistics. This is still just research data. It's unpublished, and hopefully we'll publish this soon. Just going to walk you through this quickly and show you a little bit under the hood. So if you think about a home sleep apnea test where you score no arousals, I want to show you what is the sensitivity, specificity, and accuracy. Of course, if you never score arousals and you look at epochs that have a manually scored arousal and you see how likely are we to pick those up, of course, it's 0%. You score no arousals. So every time an epoch contains a manually scored arousal, the algorithm scores no arousals. The specificity is 100%. Same reason, because every epoch that has no manually scored arousal also has no automatically scored arousals. So you're always correct there. And the accuracy, and here is where I like to point this out, is actually 78%. And why is it so high? Why is the performance of scoring no arousals in arousal scoring very high if you do nothing? The reason for this is most epochs contain no arousals. So most of the time you're correct. So this is like in Iceland, we have volcanic eruptions going on every once in a while. But if you always say there will not be an eruption today, most of the time you're going to be correct. When you are wrong, you might be devastatingly wrong. And same applies to arousals. So just as a benchmark, if you run the nocturnal PSD analysis, which in some markets has arousal scoring, we have a sensitivity of 67%, specificity 91%, and accuracy of 86%. So even if you're adding a lot of information in the scoring, the overall accuracy is not impacted so much, but you're gaining much more. So how does the Nox Body Sleep version 2 perform? It's not exactly the same as PSD, but it's getting much, much closer. And that's very encouraging to us, but it still leaves a lot of questions unopened. So what we did is that we are very lucky that we can collaborate nicely with the people at the Reykjavík University, specifically Erna Sif Arnardóttir and Anna Sigríður Ísland. And last summer, we had 10 students that were working at the Reykjavík University, looking at how does the Nox Body Sleep perform for many subtypes of sleep apnea patients. And I'm just going to share with you, because we have Dr. Sousa with us, preliminary results from the cohort with atrial fibrillation. And this is still work in progress and hopefully be published at some point soon in the future. So if we look again at the arousal scoring, it was only 48 studies that we included here, but we see that the performance of the Nox body sleep does not seem to be severely impacted when you have people who have these severe arrhythmias. And that's, positive for us. But maybe the question that's more important is like, how does it then impact the patients? Because in the end, the arousal scoring is not the end-all be-all of the home sleep apnea test. There are other parameters that may be more important. So let's first look at, how does it impact the scoring of hypopneas? If you score no arousals, you have a sensitivity of the hypopneas about 62%, and specificity is 100%. This means that 38% of hypopneas terminate in arousals, and they are missed in the home sleep apnea test. If you add the arousal scoring with the automatic analysis, you get sensitivity up to 84, 89%, depending on which analysis. So you're catching much more hypopneas. And now we're getting a little bit closer, because actually what we're most interested in is like, how does it impact the AHI and the AHI classification? Because this is in the end going to be probably the most used parameter to determine what happens to the patient in the future. And if you look at two cutoff values, so we have AHI greater than or equal to 5 and 15, we see actually that including the arousal scoring either from a PSD or the body sleep actually improves the sensitivity of the diagnosis. And now I have again the scatter plot that I had before, just to show you like before and after. But before we do that, we have also, how does it affect the atrial fibrillation cohort? We only have the results for AHI above 5, but again, we see, okay, it seems that the sensitivity is increased, and specificity is still high. So it seems that the performance of the model still applies to this cohort, which has these severe arrhythmias. Okay, so this is what the points look like now when you have applied the Nox body sleep. That's the red points, so same data, and we see that, on average, the error starts to become like equally distributed around the line of unity. And the most important thing is that in this sample of 2,400 sleep studies, there are 274 individuals who are better off or get the correct, more individuals that get the correct result when they apply the Nox body sleep compared to when we only use HSAT. And that's important, because in the end, it's the individuals who will suffer and who will suffer the risk. So just the key takeaways, of course, the HSAT studies, they estimate the AHI, and certain patient populations are affected more. So at Nox, we're researching the Nox body sleep version 2, which is an AI model to determine wake, non-REM, and REM sleep and detect arousals. And the results indicate that overall the performance is similar to a PSG. And I'm going to put like quotes on similar, because depending on how you use it, if you want to use it to diagnose narcolepsy, it's not appropriate. But for this purpose of improving the AHI, it's similar. But more work is being done to investigate specific patient subpopulations. And we'll follow up on that later. So thank you.
Thank you, everyone. These were all incredible talks. I do want to get to some questions we have here. And so please feel free to ask more questions. We have a couple here. So the first one is thanking Dr. Susana for the extraordinary presentation. I wanted to ask, what is the way forward? Simplification to increase diagnosis, or an extensive characterization of phenotypes with characterization of sleep quality? What do we really need?
It seems like there are two parallel roads in sleep medicine. On one hand, we want to diagnose all patients and treat them, because we know the cardiovascular and cardiometabolic effects of sleep apnea non-treated. And on the otherwise, we strive for new parameters to phenotype the patient. So it's difficult to have an answer for that. But I think machine learning, as we heard just Jón tell us about, will be the way. I think not all of the patients will need this extensive phenotyping, but some subset of patients will need it. mostly the non-sleepy patients. I think that it tell us, it make us it brings us many problems sometimes. So how to treat and how to approach the non-sleepy phenotype, and we know that the compliance to some treatments are not what we want. So the non-sleepy phenotype, I think it's a subset of population that we need to strive for complex parameters to have it and to study the population. But I think the ideal would be to have a simple tool that gives us many information, and I think Jón told us about that, and I think the future is closer than we think.
Great. We have another one. So this is from Marian Martinez from Spain. The enormous OSA infradiagnosis leads us to use simple diagnosis methods, but the new concept of individual and precision medicine needs more sophisticated algorithms. Scoring arousals are very important, as we've seen here today, so thank you. How could we conjugate both concepts? Maybe AI is the key.
I'll leave this to Jón.
Yeah.
I'm happy to answer this one.
Yes.
And I like when you mentioned that there seem to be like two parallel paths, you know, going more simple and then on the other hand going more complicated. I think that we don't need either or. I think we can do both. So if you think about, you know, when Rexef and Kales were like pouring over their sheets of paper, having more data meant just more work, and it was more laborsome. But today, when we have AI and machine learning tools, having more data, if it's bringing more information, it's actually beneficial. So I think going for simpler recorders, or like simplifying the data collection to a point where you're not collecting the correct information to make a decision, it's not the correct way to go down. And we believe in a concept that we call more complete, less complex. So just collecting the physiological signals that you need, and don't sacrifice on the quality of the data that you collect, but do it in a way that it doesn't become too burdensome to the patient. So instead of tethering someone to a bed at a hospital far away from home, you know, we should think about just building sensors that can be applied by the individual, still recording the same amount of information like EEG or ECG or what have you, and doing it in a way that it is easy for them to set up at home and it's easy for them to use and doesn't impact their sleep. So I think just better data and more analytics, that's totally the way forward.
Yeah,
the challenge.
Yeah.
I'm sorry.
If I may jump on that, I think, you know, let's not, you know, we think we can predict the future, but, you know, the more data that we have now, it might be, you know, good for us in the long run. And this is you know, for the European Sleep Research Society, you know, understanding more and more and more about sleep every year that, you know, goes, you know, we would have wanted more of this rich data that we can analyze retrospectively now, the more that we know about sleep. So I think, you know, let's not sacrifice the richness of the data, like Jón is saying, but, you know, it has to come with the you know, the patient have to be able to apply it, and we have to have a realistic setup of the sleep study.
Yes, the real challenge is how to incorporate all this research into clinical practice and make it easier and try to diagnose all patients, because we know the higher numbers of non-diagnosed and untreated patients.
And maybe just to answer that question a little bit, is that the key to get the research into the clinical practice is by collaborating across disciplines. So getting everyone engaged, that's the key in my mind.
And I think the symposium is the best example for that.
So is Body Sleep 2.0 more useful in mild to moderate OSA patients?
That's a great question. I think we should try to answer it. But it's, of course, if you think about someone who has an AHI of 60 plus and they have huge desaturations, Body Sleep 2 is not going to add much. I don't know if it's correct to think about like mild or moderate, but I think thinking about the patient groups that are more likely to have hypopneas that terminate in arousals, they are going to be the ones who use it. Like the example I showed, you know, someone had 0.8 in REI and then 22 in AHI, and you could see on the graph there were more extreme examples. So I think severity may not be the the best dimension there, but patient subgroups, definitely.
And I want to tell everyone we have so many wonderful questions. We're going to try to get to as many as we can. I think we have 5 minutes left. So if we don't get to it, we will try to answer it on the side. But thank you, everyone, for submitting. This next one is from Christopher McCausland from Ulster University in Northern Ireland. A brilliant presentation, thank you. A question for Jón. What are your thoughts on explainability or interpretability, sorry about that, within sleep AI? Are the algorithms accepted clinically or still viewed with some suspicion?
It's a very important question. And I think explainability and interpretability are very important topics when applying AI in any decision making. Because if you think about it, I made this parallel with Ræksafengen and CARES. What they could do with their students is that when the student made a mistake, they could ask, why did you do it like this? And they could have the dialogue and they could learn from each other and they could move on. But doing that with AI today is impossible. And I think, and this is something, it's an open question in AI. It's like, how do you have the models explain the reasoning behind what they do? And how do you interpret the outcomes? We try to think about this, especially I think when you're like with a body sleep, when you're doing something, you're not automating manual work. So a clinician cannot look at the EEG and like determine if the outcome is correct or not. And what we use is what we call the confidence plots, I think they're called in the software, where we are actually also outputting from the AI models the metric. It's a little bit difficult, but it gives you a metric. It says 10% of epochs that I've seen like this, they were scored like wake. 50% of epochs that I've seen like this, they were scored like non-REM, and 40% of epochs that were scored like this were scored as REM. Therefore, my prediction is non-REM, but this is kind of, and trying to give a little bit more intuition, but absolutely building this. If they're clinically accepted or viewed with suspicion, I think it depends on who you ask. But there, I think the only way forward today, at least, is maybe not through explainability and interpretability, but being transparent about what data you used for the training and the validation, and actively encouraging researchers to run their own validations, do their own research, and being open and sharing all the information. Because as like what keeps me up at night is that if we release an algorithm like the Nox Body Sleep, and it turns out that it causes harm to specific patient groups, I mean, that's the last thing I would want to do. And if someone finds it, please let people know.
And I think that's a good point for clinicians too, because, the question is, how do we interpret the data too when we're going through it? And you're right, and understanding that it's important that what groups you validated it in. Can you extrapolate this to all patient populations, especially those with chronic conditions like atrial fibrillation? That's very helpful. So the HSAT-H was calculated using total sleep time or total recording time?
Yeah, it was total recording time, so no information about sleep or wake.
So this may be our last question because I think we only have 2 minutes. So I'm not sure I can give you enough time for this, but it says, how does your new algorithm compare with WatchPat, please?
Yeah, does someone want to look into it? Yeah. So that's something that we haven't investigated. I don't want to speculate, but the WatchPat uses totally different technology. It's based on different physiology than the Nox Body Sleep. So WatchPat is using the pulse signal in the finger. We're using the respiratory movements. So I could imagine that there would be different medication that impact the performance of WatchPat versus Body Sleep. There might be different comorbidities that impact it differently, different body shapes you could think about. So on our end, we're trying to investigate all these things and figure out, where it's applicable and if it's not applicable for some patients. And I think ETMR should do the same thing. And then scientists should do the head-to-head comparison and interpret the results.
That is wonderful. Thank you for that. And thank you everyone so much for joining us today. We so appreciate you joining us for this past hour. And thank you to these wonderful speakers. And